start with our discussion. Today, we are going to see some important topics, okay? So, which is very, very important to deal in INISET. And before going into that, you know the new INISET pattern, I think so. They have divided into four blocks. They have divided into four blocks, okay? So, this is a thing which they have done for the INISET. So here, what they have told is they are going to make sure that you are not going to go back into the previous block. Okay, so this is going to be four block thing. Okay, and each block have 45 minutes. Okay, and you're going to have total of 180 minutes. Okay, 180 minutes. Okay, and each block will have 50 Qs into 4 equal to 200 questions. Okay, and it is going to be a random blocks. Okay, and we are not sure whether it is going to be a preclinical paraclinical block, or whether it is going to be a clinical block, or it is going to be a mixture of questions. It's going to be mixed back. We are not sure about it, but one way it is good. Okay, and another way you cannot revise it, but at the same time it is going to check your nerves, how fast you're going to do, and how good you're going to rule out the options. In that way, this is one thing which is going to be good, because you're not going to confuse. 45 minutes you're going to use for one block, and you're going to go forward to the next block, so that it will give some kind of mental peace. You will in that particular 45 minutes you're going to think about that block only. So over is over, done is done, and then you'll go into the next block, and you'll be fresh with a new block. So that way it is good, I think so. And other way is, if you have some kind of doubts when you fix it for the last few minutes or few seconds, that time it will not be beneficial. You will have a very little time to go back into the revising type of questions. So here, one thing is evident. Okay, here you have to be very sharp. You have to be fixed in your moves. Okay, it is going to be like a chessboard. Okay, where you are going to be very diligent in moving the coins. Okay, so with this slight introduction, we will go into the next important discussion. What of the purpose of the day? That is, we are going to discuss very importantly our infectious disease. And infectious disease is going to be one thing which we have kept it for last few days, and it is going to be very, very vital for your exam. Okay, so with this introduction, we will go into the subject directly. So the first topic, okay, in infectious disease is going to be pneumonia. So you people are comfortable with the color, right? You want to go to white paper or black paper? Okay, white, sir. Okay, so I'll go into the white. Okay, okay. So we are going to go into. So I will go into the very, very important topics. Okay, so first one is going to be pneumonia. So I'll make sure that this should be the last day where you're going to read pneumonia, and you should be directly going to your exam. So what is pneumonia? It is going to be an acute infection involving the alveoli, and it is going to involve the interstitium also, without destruction of lung tissue. So it involves the alveoli and interstitium without involving any lung destruction. So here what they basically mean is, it is going to be a patient coming to you where the patient is going to have an acute infection which is going to involve the lung alveoli. Okay, so whenever it involves the lung alveoli and interstitium, we have seen already, the patient will tell you that he is going to have features of type 1 respiratory failure. So basically, in your question, they're going to give features of type 1 respiratory failure, and with this, the patient is going to present. Okay, whenever this same patient, okay, has progressed, okay, and he is going to develop lung destruction. Okay, so whenever lung destruction is there, it is going to be an coalescing abscess, or it is going to be a kind of necrotizing pneumonia. Necrotizing pneumonia. So whenever it is of this sort, what is going to happen? It is going to destroy the lung tissue, okay, and it is going to cause a particular area of the lung not fit for gaseous exchange, and ultimately it is going to result in type 2 respiratory failure. So whenever a patient is coming to you and the patient is having features of type 1 respiratory failure, then you're going to think about in terms of pneumonia. And whenever a clinical picture where the patient is going to have features of type 2 respiratory failure, which we have already seen what is what, and in those kind of patients are going to have type 2 respiratory failure. Okay, so that is the pattern how the patient is going to present to you. Okay, so here we have three kinds of pneumonias. Okay, whenever you have pneumonia, you have three kinds of pneumonia. Okay, the first one is called as community acquired pneumonia. The second one is going to be called as hospital acquired pneumonia, and the third one is going to be ventilator associated pneumonia. So these are three pneumonias we have. Okay, so whenever a patient is coming to you, the patient tells history that I have fever, cough, sputum production, or whatever it is within 48 hours of hospital admission. Okay, when patient admitted or within 48 hours of admission, if the patient is going to have pneumonia, then it is going to be called as community acquired pneumonia. Community acquired pneumonia. Okay, and the most common cause of community acquired pneumonia is going to be strep pneumoniae. Strep pneumoniae. Okay, whereas a patient is admitted, okay, in hospital for some other reason, and patient develops pneumonia after 48 hours of admission, then it is going to be called as hospital acquired pneumonia. Okay, whereas you have the next definition where the patient develops pneumonia after 48 to 72 hours of intubation. Okay, so these are the three terminologies which is important, and what they did is they have combined these two terminologies, and it was earlier called as healthcare associated pneumonia, but again they felt it is not so good to classify them into one single umbrella, and what they made is now they have made two pneumonias. One is going to be community acquired pneumonia, another one is ventilator associated pneumonia. Okay, ventilator associated pneumonia. So these are two types of pneumonia which usually you will get. Okay, and the hospital acquired pneumonia, if you take, the most common cause is going to be gram negative bacilli, which is more commonly involving than Staph aureus. Okay, again, so Staph aureus spreads because of the close contact with the patient, the doctor examining the patient with Staph aureus infection or MRSA, and then he goes and touch the next patient. So it is high chances of spreading of the bacteria from one person to another person happens here. And for that reason, what is going to happen? The patient is going to present to you, followed by admission. The patient was admitted for something like a cholecystitis, for example, cholecystitis, and followed by cholecystitis. What happens? The patient develops pneumonia. Okay, so followed by cholecystitis, the patient develops pneumonia. Now you can hear me. So whenever this kind of picture is there, okay, whenever this kind of picture is there, then it is going to be obvious that it has spread from one person to another person. Okay, so it is going to be Staph aureus. Okay, I've given my maximum audio sound is there. Which slide you want me to explain? Okay, so this is the pattern of patient coming to you. Okay, this is the pattern how patient is coming to you, and based on this, you are going to decide what kind of patient or what kind of pneumonia the patient is going to have, and you're going to divide this ventilator associated pneumonia further. Okay, this ventilator associated pneumonia can be further classified into two types. Okay, early VAP and late VAP. Okay, it is further divided into early VAP and late VAP. Okay, what is this early VAP? What is this late VAP? Okay, whenever a person develops ventilator associated pneumonia within 5 days of intubation, then it is early VAP. See when say type 1 respiratory failure, type 2 respiratory failure, already we have seen, right? So type 1 is going to be where we are going to have low PO2 and normal PCO2, whereas type 2 is going to be a patient who is going to have low PO2 and high PCO2. Whenever your alveolar interface is getting involved, you're going to get type 1 respiratory failure. Whenever it is going to be a destruction and your lung goes for inexpansible state, or like the patient is going to have a restriction like pattern, okay, where the lung is not able to help in gaseous transfer even after the initiation is given by the brain, okay, then it is going to be type 2 respiratory failure. Okay, so whenever there is a destructive pathology, it is going to be type 2. Whenever it is not a destructive pathology, it is going to be type 1 respiratory failure. Okay, so within 5 days is going to be early VAP. Whenever it is more than 5 days, it is going to be late VAP. Okay, early VAP is going to be drug sensitive, and late VAP is going to be drug resistant. This early VAP has good response to treatment, whereas late VAP has poor response to treatment. Okay, the most common cause is going to be strep pneumoniae. Okay, and here the most common cause is going to be Pseudomonas. Okay, followed by we have other causes here, okay, which is going to be H. influenzae, here Staph aureus and Acinetobacter. Okay, so these are organisms which are associated with VAP, and this is going to be an early VAP and late VAP. Okay, and overall, if you ask me what is the most common cause of VAP, it is going to be our Pseudomonas. Okay, Pseudomonas is the overall most common cause of VAP. So this is one important differentiation which is going to tell you what kind of patient presentation is going to be, what kind of severity the patient is going to have. Okay, so this is very important differentiation. Okay, so whenever you have any patient coming to you with pneumonia, okay, so there is going to be high chances of resistance to treatment. Okay, and whenever it is going to be a patient who is going to have community acquired pneumonia, there is high chances because of the inadvertent use of antibiotics, the patient is going to develop MRSA. This is they're going to have methicillin resistant staph aureus. And in ventilator associated pneumonia also, there is high chances of developing MRSA. Okay, so what are the risk factors for a patient to develop MRSA? Okay, so whenever you have any patient coming to you with pneumonia, okay, the patient is going to come to you with pneumonia, and you are thinking about MRSA whenever the patient has cavitation, whenever the patient has concomitant hemoptysis, okay, whenever the patient has neutropenia, okay, and the patient has erythematous rashes, rash, okay, and whenever the patient has concurrent influenza. So it can be an influenza followed by and bacterial pneumonia. Okay, influenza followed by bacterial pneumonia. There is high chances for the patient to develop. Okay, then this is going to be important risk factors for in a community. Okay, and they also say whenever the onset of pneumonia, okay, onset of pneumonia is in summer, there is high chances of MRSA. Okay, so in summer month, if a patient is going to have MRSA, then pneumonia, then there is high chance of developing into MRSA is there. Okay, coming to VAP. Okay, VAP. When a patient can have VAP. Okay, so VAP with MRSA is associated whenever a patient is on antibiotics. Okay, in recent 90 days. Or whenever a patient is admitted in hospital, okay, for more than 2 days in last 90 days. In last 90 days. Okay, so this is going to be one important thing you're going to check in the question, okay, or in your patient. Okay, whenever a patient comes and tell you that 3 months back, 2 to 3 months back, I was admitted in hospital for some other thing, and they started on antibiotics. Okay, and that is going to be one risk factor for MRSA. Okay, and gastric acid suppression. So long-term PPI, a patient is being put on. Okay, and this long-term PPI suppression is one very, very important risk factor to develop MRSA and even infection, pneumonia. Okay, and patient is on current hospitalization for more than 5 days, then it is significant. Okay, significant. Then patient is an immunosuppressive patient, or patient summer is during summer season. If a patient gets pneumonia, then there is high chances of MRSA based on the studies. Okay, try in a lot of studies it has seen that if a patient is getting admitted in summer, okay, then he is having high chances of developing MRSA. Okay, MRSA. Okay, then patient on hemodialysis in recent 30 days. Recently, patient was on hemodialysis. Okay, so this is going to be the picture. Okay, this picture is going to be very, very important because these patients have high chances of getting into MRSA, and you start treatment. Many times patient will not respond to treatment, and you will think what is the reason for the non-responsive pattern. Then it is going to be MRSA. You have to change the antibiotics. Okay, so this is going to be few risk factors. We can ask a question in exam. Okay, a patient who is a known case of um, um, hypertension is coming to you with a history of hospitalization before 2 months for cholecystitis, and now presents with acute onset of breathlessness with cough, and the patient is not responding to treatment. Which are the following you consider as a reason for his non-responsiveness? Okay, it should be MRSA. Okay, so that is very, very, very important thing which you have to notice in your question. Okay, you have to notice in your question. Okay, so this is going to be one important thing which you're going to see. Okay, now coming to community acquired pneumonia. Community acquired pneumonia. Okay, so whenever you have a patient coming to you with community acquired pneumonia, okay, there are two types of presentation patient can have. One is going to be they can have typical pneumonia. Another one is atypical pneumonia. So whenever they have typical pneumonia, it is going to be typical presentation like a pneumonia, whereas atypical will have certain features which is not going to be very conclusive. Okay, so in typical pneumonia, we have it is different, right? Whenever it is going to be a patient who is having MRSA cap, where same, but risk factors is different, right? Risk factors is different. Okay, so whenever you have typical pneumonia, it means the infection is within the alveoli and the bacteria is lying inside the alveoli. Okay, whereas atypical pneumonia, okay, the infection is outside the alveoli. Outside the alveoli. Okay, both can lead to MRSA. MRSA means bacteria doesn't know whether it is a community or a ventilator, right? Okay, whenever there is a infection which is lying outside the alveoli, then it is going to be atypical pneumonia. Okay, so in typical pneumonia, this is going to be a sudden onset of pneumonia. Okay, sudden onset will be there, where patient is going to have typical features of pneumonia. So how the patient is going to tell? The patient will tell that I have high grade fever. Okay, and I have cough, which is going to be highly productive. Sputum will be there, and the sputum is having some kind of color. Okay, that will be the history here. Okay, whereas atypical pneumonia, it is going to be gradual progressing pneumonia. Okay, the patient will have slightly prodromal phase, followed by prodromal phase. Patient is going to have typical features of uh, pneumonia, which is very, very evident for atypical pneumonia. Okay, so it is not like typical pneumonia, it is atypical. Okay, that is very, very important. Okay, so here the patient is going to have productive cough, high grade fever. Okay, whereas these patients are going to have URA like symptoms. Okay, URA like symptoms, and followed by the patient is going to have dry cough. Dry cough. Okay, and whenever you see a typical pneumonia, whenever you see x-ray, the features of consolidation will be present. Okay, so here consolidation is absent, and here only interstitial pattern is present. Interstitial pattern is present. Okay, so this is the lung of the patient. Okay, and this is the airway, and here we have bunches of alveoli lying together. Now, whenever a patient has pneumonia, what is going to happen here? This is going to be the area which is going to have alveoli. So here there is going to be alveoli. Here there is alveoli. Okay, and it is going to fill up the alveoli. Okay, whenever you see an X-ray, okay, whenever you see here, what you see here, you see a track in between two bunches of alveoli which are having pus. Whenever it is having pus, it is going to be radio opaque, and this feature is called as air bronchogram. So air bronchogram is evident whenever there is a solidification of the lung, which is called as consolidation. Okay, consolidation. So what is consolidation? The organized pus is going to give you appearance like a solid lung. Okay, so that is called as solidification or consolidation. Okay, so this is very, very important to note here in this patients. Okay, in these patients. Then next is the patient is going to have chest x-ray, which I will again explain. As I told you, consolidation will be there, and this consolidation can involve the whole lobe or lobar pneumonia, or it can be involving the bronchi and associated area. So it is going to be bronchopneumonia. Bronchopneumonia. But here, as I told you, here it is going to be interstitial pattern. If it is going to be interstitial pattern, it is going to involve the areas around the alveoli. If this is an alveoli, I'm just enlarging the picture, where the patient is going to have pneumonia involving this area. Whenever it is going to be involving this area, okay, so it is again, now if you see, it is surrounded by a lot of alveoli. So this is going to involve this part, this part, this part, this part, this part, this part, this part. So whenever it looks like this, it is going to be showing interstitial infiltrates. And because of these interstitial infiltrates, there is going to be paucity of findings. Okay, you will feel like something is not happening. Okay, so it looks everything is fine, but why patient is having problem? Like that kind of picture will be there. Okay, so there will be paucity of findings. Okay, then next is you check for the patient, his counts will be increased, right? Obviously there is a bacterial infection, his counts will be increased, whereas here it is not so. Okay, and mostly here after doing counts, what you are going to do next step, you're going to go for a culture sensitivity. Okay, here mostly the organism is positive for culture sensitivity, whereas here culture sensitivity, no, it will be negative. Okay, because it is because of virus or atypical organisms you're going to get pneumonia, so culture will be negative. Okay, so what you do next, you plan for antibiotics. The antibiotics will be responsive here. So this is atypical and infection, so antibiotics is going to be not useful. So this is how you will differentiate a typical pneumonia from atypical pneumonia. Okay, a patient is coming to you, the patient complains of sudden onset of cough, high grade fever, sputum production, and you do a chest x-ray which shows consolidation with air bronchogram, and chest x-ray shows lobar or bronchopneumonia pattern. The next step, you're going to go for counts. Counts will be elevated, and you do a culture sensitivity, and it will turn out positive, and you start an antibiotics, patient will respond. Whereas a patient with your atypical pneumonia is going to have more of an interstitial pattern, where the patient is not having any typical symptoms or typical findings. You think, okay, it looks normal, but patient will keep on worsening. That is because of the interstitial infiltrations. Okay, and one more thing, if I can tell you, the infiltrates here is going to have polymorphonuclear cells, which is going to cause the alveoli getting flooded with the pus, whereas here it is going to be more of lymphocytic predominant. Lymphocytic predominant. And the inflammation is mediated by lymphocytes. Okay, I will X-ray. I will tell you. I will show. I will tell you. Okay, X-ray finding in atypical pneumonia is almost, it looks normal. Okay, you cannot say whether the patient has any problem or not. Okay, it is almost normal. Okay, it's almost normal. Okay, so there is going to be not much of findings to get in patients with consolidation. Is not destruction. It is just solidification. Whenever your alveoli is getting involved, okay, whenever your alveoli is getting involved, what type of respiratory failure are you going to get? Type 1. So if it is going to be a necrotizing pneumonia, then you're going to go to type 2. Okay, whenever there is a destruction of the lung parenchyma, okay, whenever there is a damage to the alveoli and the interstitium, it is destroyed, then it is going to be having type 2 respiratory failure. Okay, so now here we have 4 important pneumonias, okay, which I have to discuss as etiological factors. The first one is going to be streptococcus The second one is going to be Staphylococcus. The third one is going to be Klebsiella. Another one bacteria I will discuss separately. Okay. So whenever you have a patient is coming to you with streptococcal pneumonia, the patient will have a history that he is alcoholic, diabetic, and a smoker. So he is going to have addiction to alcohol, diabetic, and he is a smoker. Okay. And whenever you ask clinical features, he is going to have typical features of pneumonia, and the pneumonia is going to have red, rusty sputum. Okay, red, rusty sputum. Okay. So what you're going to do next step? So you think it is a pneumonia, you go for a chest X-ray. Chest X-ray again, as I told you, it is going to have mostly lobar pattern. Lobar pattern. Okay, lobar pattern. Whereas if you take Staph aureus is going to be seen more commonly among IV drug abusers. IV drug abusers in setting of hospitals. Hospital acquired. Okay, here the patient is going to have mucopurulent sputum. Mucopurulent sputum. Now visible. Now visible, right? Mucopurulent sputum. Okay, and the patient is going to have a typical patchy consolidation or bronchopneumonia-like feature. Bronchopneumonia-like feature. Bronchopneumonia-like feature. So how this patient is going to present whenever he has a lobar pattern, he is going to have a lobar pneumonia. Okay, so it is going to be involving a particular lobe like this. So the patient will have haziness like this. Okay, whereas whenever he is going to have a bronchopneumonia, okay, this patient is going to have a pattern which is extensive, but it is going to be like this around the bronchus. Okay, so that kind of patchy involvement will be there in bronchopneumonia. Okay, the next one is going to be Klebsiella. Okay, so whenever you have Klebsiella, you have to think whether the patient is an alcoholic or not. Okay, alcoholic are highly having chances of getting pneumonia, and that is going to be again associated with Klebsiella, and malnutrition is one risk factor. Okay, here the patient is going to have a kind of sputum, okay, which is going to be a red currant jelly sputum. Okay, it is a red currant jelly sputum. Okay, and this patient is going to have pneumonia, and this pneumonia will be causing a bulge in the we will do. Okay, so it will be uploaded in the app, I think. Okay, so you get a bulge here. Okay, this is called as bulging Fisher sign. Bulging Fisher sign. Okay, so bulging Fisher sign. Okay, and this pneumonia can further progress into abscess. Okay, this can progress into abscess, and this abscess can ultimately develop into a cavity. Okay, so there is high chances that it can develop into abscess and followed by a cavity. Okay, so these are few things which you get to see with Klebsiella pneumonia, and this bulging Fisher sign was again an MCQ last year. Okay, very important thing to note. Bulging Fisher sign is a very important thing to note here. Okay, then next one is going to be the killer one. Okay, which is going to be your Pseudomonas. Okay, Pseudomonas. Okay. So Pseudomonas is going to be again a killer one. Okay. So whenever you have Pseudomonas, it is associated with HAP. Okay, HAP. Okay, and VAP. Okay. So whenever you have any structural lung disease, okay, patient has a structural lung disease, that is, patient is coming to you and tells, sir, I have history of bronchiectasis, bronchiectasis, or I have cystic fibrosis. Then you think about Pseudomonas more than Staph aureus. Okay, so whenever a patient is telling that, sir, I have a previous history of cystic fibrosis, bronchiectasis, COPD, okay, now I have cough with sputum protection, then you have to think highly vigilant about Pseudomonas. Okay, so how this patient is going to present? It is going to be again fever. You are admitting the patient, you ask for history, he is having mucopurulent sputum. Okay, so he's going to have a productive cough. Okay, and you do a chest x-ray which is going to show bilateral infiltrates. Okay, it can be both lobar pattern and bronchopneumonia pattern. Okay, bronchopneumonia pattern. Okay, so this is one thing a patient can present with. Treatment we will discuss later. And the last one, just here, Acinetobacter, which is going to be again associated with VAP. Okay, and this patient is going to be, one thing I want to tell here is, these patients initially you have to start with carbapenems. Okay, carbapenem is meropenem and imipenem, followed by colistin. Okay, followed by colistin. That will be the treatment, because the patient even will be resistant to carbapenems. Okay, so these pneumonias are going to be typical pneumonias. Okay, they are going to be typical pneumonias. Okay, typical pneumonias. Whereas you have certain conditions where atypical pneumonias will be there, and the patient will have paucity of symptoms. Okay, atypical pneumonias and paucity of symptoms will be there. Okay, so what are those pneumonias? Okay, so in atypical pneumonia, we have few important things to know here. Okay. Okay. So atypical pneumonia, you have very, very important two pneumonias, okay, which is going to be Legionella, Mycoplasma. So atypical pneumonia, important thing, Legionella, Mycoplasma. Even though Legionella is a typical bacteria, it is going to cause atypical features. Okay, so how it is going to be spreading? Okay, so whenever you have Legionella, your question will say patient is having micro aspiration. So patient had food followed by he had a cough and patient developed pneumonia. Okay, or there will be history of aerosolization. So how the patient is going to present is, the patient will tell history. I went to a conference. In the conference, there was a very chill AC, and I was feeling better when I was there. And I came out. I started developing body pain, followed by I have fever and I have dry cough. Okay, so that kind of things is going to be seen with your Legionella pneumonia. Okay, Legionella pneumonia. Okay, so Legionella pneumonia is one thing where the patient is going to present differently than your other commonly known bacteria. Okay, so whenever you have Legionella pneumonia, okay, the patient is going to have CNS involvement. Okay, so here I want, before that I want to tell two important things here. In Staph aureus, you have a cavity. Okay, cavity. Okay, so cavity is going to be called as pneumatocysts. So the thin walled cavity in patients with Staph aureus is going to be called as pneumatocysts. Okay, pneumatocysts. Very, very important thing. Okay, nematocysts. Okay, and in streptococcus, okay, in children's you have pneumonia which is localized to one area, okay, like this. Okay, and this is called as round pneumonia. In children it is seen round pneumonia. Why it is seen in children? Okay, in children it is seen. Why it is called is seen in children, not in adults? Okay, so if you take the children's, okay, children, you have in alveoli like this, one alveoli, another alveoli is like this. Okay, another alveoli is like this. Okay, these two alveoli are connected by pores of corn and canals of Lambert. Okay, so this should be well developed when you are going to be an adult. Okay, and this, whenever well developed in adults, it is a communication path between two alveoli. Okay, now what happens in children, the pores are not well developed, and whenever you have a pneumonia, the pneumonia infection will be localized to one area of the lung. Okay, and that is called as round pneumonia. Okay, that is called as round pneumonia. Okay, so it is seen in children. Okay, not in adults. Okay, not in adults. This is very important thing. Okay, very important thing. Okay, now the next important thing is, whenever you have a patient coming to you and you think about legionella pneumonia, okay, the patient is going to have typical CNS features. Okay, typical CNS features. Okay, the patient will be in delirium. Okay, whenever you have a pneumonia and they give delirium, okay, along with the delirium they give hyponatremia. Hyponatremia, then high chances that this patient is going to have CNS involvement, and it is going to be high chances that the patient is going to have Legionella pneumonia. Okay, Legionella pneumonia. Okay, and these patients can present with headache. Okay, headache. And in GI manifestation, the patient is going to have diarrhea, headache with diarrhea. And if you see the LFT, the LFT will show elevated SGOT and SGPT. There will be transaminitis. Okay, and the patient sometimes even can have thrombocytopenia. Thrombocytopenia. Okay, and these patients will be gram state negative, culture sensitivity negative, and they have poor response to antibiotics. They will not respond to antibiotics. Okay, poor response to antibiotics. That is one feature which is going to tell you this is a case of Legionella pneumonia. Legionella pneumonia. Okay, Legionella pneumonia, which will be evident with this clinical features. Okay, so whenever you have any patient is coming to you like this, then think about your Legionella pneumonia. So any patient in your question is given, okay, or a patient is coming to you, patient is telling, I have patient relative is telling to you, sir, morning he was fine, sir, suddenly he developed a altered speech. He was talking something which is very irrelevant, and he is having hyponatremia like features. Okay, then you do the sodium, okay, and sodium is turning out to be low. Okay, then high chances this patient is having your Legionella pneumonia. Sorry. So, okay, for that reason, you have to be very diligent in your history whenever you are going to treat any patients with pneumonia, because all pneumonias are not same. Okay, all pneumonias are not same. Okay, for that reason, you have to be very careful in your uh, history. Okay, so how to diagnose this pneumonia? Actually, if you see, the pneumonia can be just diagnosed by two things. One is serology. Okay, you go for serology, or you can also you go for urine card test. Okay, this is one pneumonia which can be diagnosed in urine. Okay, so the antigens in the Legionella pneumonia is excreted in the urine. For that reason, you can go for urinary antigen test. Okay, for Legionella. Okay, for Legionella. Transaminitis means increased in OT and PT. transaminase enzymes. Okay. So here, since it's atypical pneumonia, I will do the treatment here itself. Okay. So treatment, if you take Legionella, it actually responds to fluoroquinolones. Okay, it responds to fluoroquinolones, especially Levoflox. You can also go for Moxiflox. Okay, these two antibiotics are responsive. Okay, responsive in this patient. Okay, so this is about your Legionella pneumonia. Okay, Legionella pneumonia. Okay, then next is Mycoplasma. Okay, Mycoplasma. If you take Mycoplasma is the most common atypical pneumonia. Even though I told you atypical pneumonia is more common in viral infections, but Mycoplasma is the OTPT means OTPT means SGOT, SGPT, AST, ALT. Okay, ALT and AST. Most common atypical, okay, pneumonia. Okay, so this agent, Mycoplasma, is also called as Eaton's agent. It is also called as Eaton agent. It is a name given to it. Okay, and it is also called as walking pneumonia. Walking pneumonia because it is like an infiltrate which moves increases around. Okay, walking pneumonia. Okay, this pneumonia is also going to present with extrapulmonary features. Atypical features of pneumonia will be there, with extrapulmonary features will be there. Okay, so how this patient can present? This patient can have associated CNS manifestation. Okay, CNS manifestation in the form of Guillain-Barré syndrome, encephalitis. Okay, then patient can have skin manifestation. Skin manifestation in the form of erythema nodosum. Okay, then what they can have heart involvement. The patient can present with pericarditis, myocarditis. Okay, the patient can have blood involvement in the form of hemolytic anemias. Okay, and the patient can have joint involvement with arthritis. Okay, so these are multiple manifestations of your patient with mycoplasma pneumonia. So mycoplasma pneumonia, along with atypical features, they will have multiple organ involvement. Okay, so suddenly the patient is admitted and developing breathlessness. Okay, and patient, if you see, the patient will be drop positive. Then you see why the patient with pneumonia is developing drop positive. It might be because of the myocarditis. Okay, and patient can develop multiple nodules. Okay, like features or something like a discoloration over the skin. Okay, that is erythema nodosum can be there. Patient pneumonia followed by patient developed weakness involving lower limbs, okay, which was a progressive ascending palsy, then Guillain-Barré syndrome. So whenever your patient is going to present like this, then you are going to think about mycoplasma pneumonia, and this bacteria does not have cell wall, does not have a cell wall. Okay, so there is no cell wall, so it is not going to be cultured. Okay, or it cannot be gram stained. So the investigation what you're going to do here is going to be PCR. Okay, and treatment wise, if you see, the treatment is going to be macrolides. Okay, macrolides, that is our azithromycin, or you can go for tetracycline. Okay, so this is the treatment of patients with mycoplasma pneumonia. So mycoplasma pneumonia patients are going to present with more of a atypical feature. Okay, atypical feature. Okay, so this is about your atypical pneumonia. Here I want to talk about one more pneumonia which is caused by a fungi. Okay, and it is called to be pneumocystis pneumonia. Pneumocystis pneumonia. So whenever you have any patient coming to you where the patient is immunocompromised, okay, immunocompromised, especially whenever the patient is having features of your HIV, okay, HIV, then think about your PCP pneumonia, okay, PCP pneumonia, okay. So whenever a patient is coming to you and the patient is having history of HIV, then think about PCP pneumonia, okay. So if you take patient PCP, it is a fungi, okay, and it is seen in immunocompromised patients, okay. If you take HIV, the most common, okay, opportunistic infection, it is going to be tuberculosis, okay, and most common pneumonia in HIV patients, again it is going to be TB, okay. The most common cause of pleural effusion, it is going to be TB, but most common cause of fungal pneumonia, then it is going to be pneumocystis carniae pneumoniae, okay. So what are the risk factors to develop PCP, okay? Whenever your CD4 count is less than 200, okay, then it is going to be a risk factor. Then next is organ transplant patients. Organ transplant patients have high risk for PCP. Then patient on immunosuppressive treatment. Immunosuppressive treatment. Then it is associated with PCP. And whenever patient has primary immunodeficiency, then it is going to be associated with PCP pneumonia. Okay, so how the patient is going to have clinical features? Again, it is going to be more like a atypical pneumonia, where patient is going to have fever, dry cough, and this interstitial pneumonia. So what kind of breathlessness you will get? What kind of breathlessness you will get in interstitial pneumonia? So we've seen few people, we have discussed about interstitial lung disease. So on exertion, you will get shortness of breath, exertional breathlessness. Okay. So chest X-ray, whenever you do in this patient, the chest X-ray will be initially normal, very good, normal. Okay. Followed by the patient is going to have bilateral infiltration. Okay. And this infiltration is going to be a perihilar infiltration. Perihilar infiltration. So the patient is going to have infiltrations perihilar like this. Bilateral perihilar interstitial infiltration. Bilateral perihilar interstitial infiltration. Okay, while bilateral perihilar interstitial infiltration, it will look like this. Okay, it will look like this. And what is the best diagnostic method? Okay, the best diagnostic method is you go for ball. Okay, ball. Okay, which is more specific than sputum. Okay, and whenever you do a ball, you stain it for right Giemsa staining, Gomori methanamine staining, Gomori methanamine staining. Okay, and after staining, what you get to see is you get to see the cyst. Okay, cyst. And what is the drug of choice here? Drug of choice. So whenever you consider drug of choice in PCP pneumonia for treatment, it is going to be Septron or cotrimoxazole. Cotrimoxazole. And for prophylaxis also, you go for cotrimoxazole. So it is used for both treatment and prophylaxis. Okay, treatment and prophylaxis. So whenever there is a contraindication for cotrimoxazole, what drugs you can prefer? Okay, you can prefer trimethoprim plus dapsone. Okay, so any patient, okay, with the HIV, whenever there is a high risk for any kind of pneumonia, especially if it is going to be high chance of PCP pneumonia, then you go for cotrimoxazole prophylaxis. So cotrimoxazole is given in all patients with HIV. Okay, in all patients with HIV. All patients with HIV. Okay, what are the other things? You can go for aerosolized pentamidine. Aerosolized pentamidine. You give nebulization with pentamidine. Okay, there is a special chamber or a device to go for pentamidine nebulization, that is called Respicar, but name is not important for you. But you just know if you go for aerosolized pentamidine, and this was INISEC question. Okay, INISEC question. Okay, so these are the available things, and you can also add Ottawa cone. These are the available treatment. Okay, so what is the role of steroids? Okay, steroids. When you are going to give steroids, okay, in PCP pneumonia. Okay, so whenever a patient has a PaO2 less than 70 millimeter of mercury, okay, so it means that the patient is having severe inflammatory response. In those patients, you can have steroids. Okay, you can have steroids. So steroids are given if the patient is having high chances of hypoxemia. Okay, and especially whenever your PaO2 is less than 70 millimeter of mercury, then you can go for um, steroids. Okay, so these are few things which are going to be very very important in assessing the patient. Okay, so patient comes to you HIV, and in HIV patient is having shortness of breath, and along with this you do a ABG and PaO2 is less than 70 millimeter of mercury, and you think it is a PCP pneumonia and you want to act immediately, then you go for steroids. Okay, steroids is going to be again a game changer in PCP pneumonia. Okay, and this is again a very very important MCQ for your exam. Okay, very very important. Presence of cyst means it contains a fungal hyphase. Okay, the fungal hyphase cyst. Okay, it is exudates. Patient is already immunocompromised, but patient is having inflammatory response, right? Then how you can stop the inflammation? When you want to stop the inflammation, how you're going to do it? Patient is already on Septron, patient is not responding, then you have to go for these drugs. Okay, so this is a treatment. Okay, this is the treatment. Okay, so this is very very important. Okay, so when you will stop, one question being asked in exam is when you will stop the prophylaxis. Okay, patient already. Okay, so patient is already on treatment. Okay, so you are giving patient cotrimoxazole. Okay, and you feel that patient is improving. Okay, and you want to stop the prophylaxis. Okay, when you will give stop this prophylaxis, whenever your HIV viral load is less than 50 copies, and CD4 count is more than 200. Okay, whenever your HIV viral copies is less than 50, and whenever your CD4 count is more than 200 for 3 months, okay, then what you can do is you can go for stopping the prophylaxis. When you can stop the prophylaxis. Okay, so this is about your pneumocystis carinii pneumoniae, and this pneumocystis carinii pneumoniae is one feature with which patient can present to hospital. Okay, so patient will tell history of fever, dry cough, and history of HIV or immunosuppression, comes to hospital, okay, and you do a chest X-ray, you see peripheral uh, normal feature and perihilar haziness, okay, that haziness is going to give you that patient a clue that patient is having PCP pneumonia. You start a treatment, plan for a ball, take the ball and stain it with the right Giemsa staining and Komori methanamine saline, which is going to tell you about the hyphae, fungal hyphae present. Okay, and this was a question asked in again last but before your NEET exam. Okay, and what is the drug of choice? Treatment is going to be cotrimoxazole. Prophylaxis is also going to be cotrimoxazole, and you have alternates, which is going to be one important thing is aerosolized pentamidine. Okay, it is given by a nebulizer chamber called a Respigard nebulizer chamber. Okay, Respigard nebulizer chamber. Okay, so these are few important things about your patients with PCP pneumonia, and this is very important thing to know for your exam also. Okay, so finally we are coming to investigations in patients with um, pneumonia. Okay, investigations in patient with pneumonia. Investigations. Okay, so whenever you plan for investigations, okay, so how we are going to go about with investigation? Okay, so the routine investigation which we are going to do in all patients is going to be uh, WBC count you are going to do, ESR CRP you are going to do, it is going to be elevated. Okay, next is sputum. Okay, sputum. Whenever you check for sputum, okay, whenever you check for sputum, okay, so sputum, okay, so sputum, okay, so sputum, whenever you collect sputum, okay, one thing I want to tell here is every time we collect sputum, okay, but we don't know how good this sputum is, okay. For that we have a scoring system called Bartlett scoring, okay, Bartlett score. So Bartlett score will tell about the quality of the sputum, okay, quality of the sputum, okay. So a sputum is high quality sputum. High quality sputum. When you are going to tell it as a high quality sputum, okay, when you are going to tell the sputum is high quality sputum, whenever just the amount of sputum or the sputum color is not going to tell you that it's a high quality sputum. You have to see for how good the sputum is. Okay, so for this you have to see for the number of polymorphonuclear cells. Okay, whenever the polymorphonuclear cells are more than 25 per low power field, okay, and it has epithelial cells, okay, squamous epithelial cells less than 10 power per low power field. Okay, video is on, right? There is no problem, right? Yes, okay. So whenever you check for any sputum, the sputum should have a polymorphonuclear cells which is more than 25 per low power field, and squamous cells should be less than 10 per low power field. Okay, so what you will think about a sputum which contains more than 10? What is your feel whenever it is containing more than 10 squamous epithelial cell? What you feel like it? It is going to be salivary contamination. Very good. Okay, so it is going to be salivary contamination. Okay, so for that reason you should be very sure what kind of sputum the patient is going to give. Okay, lot of times we will never think about these things, right? We will ignore. Okay, the PG will tell collect the sputum, we will collect the sputum and send the sample. Okay, and what will happen is ultimately the patient is going to have these kind of report coming as inconclusive. Okay, or it will tell a report which contains normal salivary or normal flora is grown. Okay, so what like that picture will be there. Okay, we have to be very careful when they're sending the sputum. Okay, and it should be a productive cough where you're going to get a high yield sputum. This high yield sputum is going to give you a report, okay, report which is going to be positive, okay, positive, right? So this is very, very important to note here. Bartlett score is the score. There are a lot of gradings and all there, but I don't want to go into the grading, okay. Next is, along with this, we are going to go for chest x-ray. You get chest x-ray, okay. So chest x-ray is very, very important, okay, very, very important, okay, because this chest x-ray is going to give you a lot of differential diagnosis. Sometimes it is going to be yielding, sometimes it is going to be non-yielding, okay. For example, I'm going to give an x-ray like this, and this x-ray is going to be showing opacity like this, opacity like this, okay. Whenever it shows an opacity like this, okay, what we will think usually, it is it is looking like a opacity, okay. This opacity is going to be lobar pneumonia, lobar pneumonia, okay, lobar pneumonia. This is lobar pneumonia, okay. And in this lobar pneumonia, you get to see an appearance in closer view like this. What is this called as? What is this called as? These are called air bronchograms, okay. Air bronchograms are evident in chest x-ray. Air bronchograms are evident in chest x-ray, okay, evident in chest x-ray, okay. So this is very, very important thing you get to see here, okay, so get to see here, okay. So this lobar pneumonia area is going to be called as consolidation, okay, consolidation, okay, it is going to be called as consolidation, okay. This is called as consolidation. Whereas sometimes what you get to see here is, you get to see this is a normal lung parenchyma, normal lung parenchyma. In this normal lung parenchyma, you get to see like this, like this. What is this? What is this pneumonia? This pneumonia is bronchopneumonia, bronchopneumonia, okay, bronchopneumonia, okay, patchy consolidation, bronchopneumonia. Sometimes you get to see like this, infiltrates seen like this, like this. What is this? This is going to be interstitial pneumonia, interstitial pneumonia, okay, interstitial pneumonia, okay, interstitial pneumonia. So these are few things which you have to notice whenever a patient is coming to you with pneumonia and you do a chest x-ray and you're going to get this pattern, okay. So this is very, very, very important, okay. After this, what you're going to do is, you're going to, you OPD basis, you did these things, okay. And what you're planning is, okay, this patient looks a little bit uncertain to me, okay, let me grade the patient, okay. You feel like this and you do scoring, okay. And the scoring is called curve 65 scoring, okay, curve 65 scoring. What is curve 65? It is going to be a few parameters which are very, very important parameters, which is going to be confusion, blood urea nitrogen more than 7 millimoles per liter or 19 milligram per deciliter, okay. Respiratory rate blood pressure. Okay, respiratory rate more than 30 and blood pressure more than, okay, less than 90, less than 60, and age 65. Okay, so this is curve 65. So patient has confusion, blood urea nitrogen, okay, or you can consider it as urea, okay, respiratory rate, blood pressure, and age of the patient. Okay, so here you're going to follow a simple rule. Okay, simple rule. Okay, what is a simple rule you're going to follow? Okay, you're going to follow it as 1, 2, 3. Okay, so each one has 1, 1, 1, 1, 1 as the score. Okay, so now we are going to keep it as 1, 2, 3. Okay, one is treat the patient in OPD, send home. Treat the patient in IPD, in ward. Treat the patient in IPD, ICU. That is the rule. Okay, so this is called as curve 65 score. Okay, curve 65 score. Curve 65 score. Curve 65 score. Curve 65 score. Okay, so whenever a patient comes to you and you think about pneumonia, you have to calculate curve 65, make it a regular practice. And whenever your patient is having confusion, blood urea nitrogen more than 90 milligram per deciliter, so how you're going to calculate blood urea nitrogen? It is going to be urea divided by 2. Okay, respiratory rate more than 30, blood pressure 90 by 60, and age of the patient is 65 or more than that. Okay, then this patient is having higher risk for developing severe pneumonia, so you have to classify the patient as 1, 2, 3. Okay, so this is going to be called as our curve 65 scoring, and this scoring is going to tell you about the type of treatment you're going to give to the patient. Okay, here we have another one thing. Okay, another one thing. Okay, what is the another thing here is going to be? It is ATS IDSA criteria. ATS IDSA criteria. What is this ATS IDSA criteria? Okay, here you have a major criterion and minor criterion. So the major criterion here is patient coming to you septic shock with vasopressors. Septic shock with vasopressors, or respiratory failure, okay, respiratory failure, okay, with mechanical ventilation. Okay, so respiratory failure with mechanical ventilation. Respiratory failure with mechanical ventilation. Respiratory failure with mechanical ventilation. Okay, septic shock with vasopressors, or respiratory failure requiring mechanical ventilation. What is a minor criteria? Minor criteria, you are going to see few important things. Okay, so the few important things is same like your curve. Okay, curve. So here the patient has confusion, okay, uremia with a blood urea nitrogen more than 19. Okay, then R for your patient is having respiratory rate more than 30. Okay, and blood pressure is going to be low. Okay, blood pressure is low. They have not given any cutoff here. With fluid restriction, fluid uh, uh, treatment, the patient is non-responsive. Fluid resuscitation, the patient is non-responsive. So these 4 parameters are almost the same. Okay, apart from this we have few things. Okay, apart from this we have few things. The first one is temperature. Okay, the temperature is less than 36 degrees Celsius. Hypothermia is there. Okay, then next is the patient is going to have something which is very, very important, is going to be the patient is having multi-lobar infiltrations. Okay, multi-lobar infiltration. Okay, then you see for leukopenia, thrombocytopenia, PaO2 by FiO2 less than 250. PaO2 by FiO2 less than 250. So chest X-ray show multilobar infiltrations. Then patient is having leukopenia. Patient is having thrombocytopenia. Okay, so these three parameters, M, L, T. Okay, M, L, T. Okay, these three parameters are taken into account. Okay, three parameters are taken into account. Okay, so this is about the features you get to see in patients with pneumonia, ATS, IDSA criteria. Okay, according to this criteria, what happens is you require one major or three minor. Okay, whenever it is present, one major or three minor is present, it is considered as severe pneumonia. Okay, it is considered as severe pneumonia. Whenever a patient has one major, okay, or three minor, it is going to be considered as severe pneumonia. Okay, it is going to be considered as severe pneumonia. Understood? Understood? It is going to be considered as severe pneumonia. Okay. So MLT, PaO2, FiO2. Okay. So this is very, very important because this is going to guide you to go for treatment. Okay. This is going to guide you to go for treatment. Okay. So whenever you have any patient coming to you with history, suggestive of CAP, the patient, American Thoracic Society. Okay, American Thoracic Society. Okay, so American Thoracic Society is one which is like your what to say, it's going to be one authority which is going to tell you which kind of protocol to be framed, etc. Okay, so that is very, very authoritative thing. Okay, so that authoritative thing is going to tell you how kind of how you are going to go for treatment in patients. Okay, and IDSA is Infectious Disease Society of America, and that is also one thing which is going to tell you frame protocols in various treatment parts. Okay, so what is the treatment of patients? Okay, so now whenever your patient is coming to you with any history which is suggestive of pneumonia, what you're going to do is you are going to go for curve score. Okay, curve score. Okay, so we have a lot of scoring systems here, but I'm going to another one, pulmonary severity index, but I'm not going to confuse you there. Okay, we'll stick on to curve. That will be the thing which will be asked in the exam. So whenever a patient comes with curve, okay, so curve is more than 2 or curve is less than 1. Okay, curve is less than 1. Okay, whenever curve is less than 1, you are going to treat the patient in OPD. Okay, and whenever you are treating in OPD, you see for risk factors for MDR. Okay, so first thing is the risk factor you are going to check commonly is any IV antibiotics in last 90 days. Okay, whether patient is having any immunosuppression. Okay, or whenever a patient has chronic diseases, okay, then it is going to be a risk factor for MDR. Okay, so IV antibiotics in last 90 days, immunosuppression, and chronic disease in last 90 days. Okay, if it is going to be yes, okay, yes, then what you're going to do is you're going to go for treatment with beta lactam and macrolide. Okay, beta lactam plus macrolide. So you're going to go for beta lactam plus macrolide. Okay, what beta lactam usually we will go for? You're going to go for treatment where it is going to be OPD based treatment. So you're going to go for oral treatment. So remember amoxiclav, okay, or you can go for cefuroxime, or you can go for cefodoxime. So remember it is OPD basis, okay, and you have to go for azithro or clarithro. So this is a treatment, or you can go for fluoroquinolone. Fluoroquinolone, okay. In fluoroquinolone, you are going to go for three drugs, okay, gemfloxacin, moxifloxacin, levofloxacin. Out of these three drugs, you are going to select one drug, okay. Out of these three drugs, you are going to select one drug, okay. Gemfloxacin, moxifloxacin, levofloxacin. What we commonly use is levoflox. But you have to be very careful in giving levofloxacin in countries like India, because we have already have resistance to tubercular drugs, and levofloxacin is used in MDR TB. So you should be very careful. Don't give unnecessary antibiotics like levoflox in all patients. Okay. Then next is, if it is going to be negative, okay, whenever it is negative, what you're going to do is you're going to turn mad. What? Mad. Okay. What mad is, you're going to go for macrolide, okay, or amox, or you can go for doxy. Okay, so you're going to turn mad, okay, whenever you have OPD based treatment. Okay, so it is going to be macrolide or amox or doxy. Nowadays amox and all does not work actually. Okay, so you go for a macrolide or a doxycycline whenever it is going to be OPD basis. Okay, next is whenever the score is more than 2, okay, so you're going to treat the patient as IPD patient, right? Inpatient. Okay, whenever you have inpatient treatment, okay, you check whether the patient has risk factor for pseudomonas. Okay, if patient is having risk factors for pseudomonas, you have to check whether yes, no. Okay, whenever it is no, okay, then what you're going to do is you're going to see whether the patient is having major criteria of ITSA. Major criteria of ITSA. Okay. Then if patient has major criteria of ITSA, okay, then what you are going to do is you are going to admit in ICU. Okay. If no, yes. Okay. If no, then you check for more than 3 minor criteria present. Okay, 3 minor criteria is present. If more than 3 minor criteria is present, then it is going to be again to ICU. Okay. If it is not more than 3 minor, okay, then what you're going to do is you're going to treat the patient in ward. Okay, how we are going to treat the patient in ward? You are going to start on IV beta lactam. So what IV beta lactam usually we give in our wards? We give ampicillin, okay, zone, taxine, etc. Okay, so IV beta lactam you are going to add. Okay, along with this, what you're going to do is you are going to add MAD. Here MAD is macrolide, azithro, or doxy. Okay, doxy. Okay, this is the treatment. Okay, if it is going to be ICU, you give beta lactam. Okay, beta lactam. Along with beta lactam, what you're going to do is you are going to add any of the following drug IV. Okay, any of the following drug IV. Okay, where you are going to add, okay, MAD, macrolide, azithro, or doxy, or levofloxacin. Okay, or you're going to add on moxifloxacin. Okay, any of these drugs. Okay, everything is IV azithromycin or IV levofloxacin. Okay, or you can go for you can go for doxy, etc. Okay, whenever you are going to have risk factor for pseudomonas, whenever you have risk factor for pseudomonas, okay, then what you're going to do is you are going to add anti-pseudomonal drug. Anti-pseudomonal drug. In anti-pseudomonal drug, we have drugs like piptas, meropenem, okay. Then we have cefepime, okay. Ceftazidime, cefepime, okay. These drugs are combined with these drugs, okay. Which one? Which one you want to know? ICU. In ICU, you are going to add beta-lactam plus MAD-LM. Okay. In what you are going to add beta-lactam with MAD. Okay. In pseudomonas patient, anti-pseudomonal plus MAD. Understood? Pseudomonas, anti-pseudomonal drugs. Piptas, meropenem, ceftazidime, cefepime. Understood? See, these are protocols. Okay, we cannot. Yeah, any of these. Okay, MAD. All these MAD. Out of these MAD LM, one drug. Out of this MAD LM, one drug. Out of this MAD LM, one drug. This is combined. MAD LM, one drug. In this MAD LM, you have to select one drug. What is MAD LM? LM is levomoxy. Levoflox, moxiflox. Levoflox, moxiflox. Understood? Understood? I see. See, ICU. See, whenever you have ICU, what you're going to do? You are going to combine beta lactam with MAD, LM. Okay. Whenever it is what? Speak clear, right? Whenever it is what, you are going to go in this direction. You. Then what you're going to do? You are going to go in this direction, in this direction. Whenever it is pseudomonas, then you're going to go in this direction. Understood? Yes or no? See, simple. Whenever you are treating in OPD, okay, what you're going to do? You are going to go for checking. Now it is visible or not? Whenever you are in OPD, okay. So what you're going to do? Patient is having no risk factor, okay. Then you go for MAD, okay. Whenever patient has risk factor, beta lactam plus MAD or a fluoroquinolone, okay. Whenever you have a patient to be admitted, okay, and that patient requires beta lactam plus MAD. Whenever patient is admitted in ICU, beta lactam plus MAD LM. Whenever it is pseudomonas, then it is going to be anti-pseudomonal drugs. Along with anti-pseudomonal drugs, what you're going to give? You're going to give MAD LM. Okay, very very simple. I will consolidate here. Okay, whenever it is OPD, okay, risk factors present, then what you're going to go for? You're going to go for beta lactam plus MAD or fluoroquinolone. Okay, whenever no risk factor, you go for MAD. Whenever it is what? Beta lactam plus MAD. Whenever it is ICU, then IV beta lactam plus MAD LM. Whenever it is pseudomonas, then it is going to be anti-pseudomonal plus Madeline. Understood? Yes, this is the treatment. I think I have consolidated everything. Okay. So this is very, very important. Okay. So here only it is going to be very, very importantly, it is going to be macrolide with azithromycin. Here it is going to be amox. Only drink. But you can ignore this amox. If you want, you can ignore this amox. In our condition, they have used amox left and right, that it is not going to be very much sensitive in pneumonia. It can be given in small abscess, sore throat with pharyngitis, etc., but not so useful in patients with pneumonia as such. Okay, so with this, we are finishing our very, very important thing, which is going to be community acquired pneumonia. Okay, so here I will give you a 10-minute break. Okay, so see, I have recapped here. So you can see the recap. Or even you can see here. This is a recap. The whole recap is here. The whole recap is here. The whole recap of treatment is here. So you, whenever you want to admit in OPD, what score you are going to see? Curve 65, right? Whenever it is going to be what? After curve 65, what you are going to see? Class will be till 5 o'clock. Mostly till 5 o'clock. Infectious Society of America. You know, right? Pseudomonas. All VAP risk factors are going to be Pseudomonas risk factors. All VAP risk factors are again going to be Pseudomonas risk factors. OPD basis, when you're going to treat, you're going to see here these risk factors. These risk factors are present, these risk factors are absent. These risk factors. Understood, Dr. Nandini? Risk factor absent means then you're going to go for MAD alone. This MAD. Risk factors are absent, then you're going to go for this MAD. Okay. So we'll go for a 10-minute short break. Okay. So we'll next go into VAP. Okay. So since it's online, I will give you enough time to uh, relax. 10 minutes you can relax. Then we will go into the next topic. Okay. And one more thing here I want to add here is going to be, if the patient has risk for MRSA. Okay. Whenever a patient has risk factor for MRSA, then along with this regimen, you are going to add Vanco or linezolid. Vanco or linezolid. Okay. And if plus or minus Clinda. That also you can add. If it is going to be risk factor for MRSA, then Vanco or linezolid with or without clindamycin. Again, clindamycin adding is going to be the physician's choice. The physician's choice. Understood? So we'll go for a what drug? Which drug you want? See, if it is going to be an MRSA patient, then you are going to add vancomycin or linezolid with or without clindamycin. MRSA. So I told you, right? MRSA risk factor I have already told you. If you have an added MRSA in growth, then you have to add vancomycin or linezolid. Along with this, you're going to add clindamycin. Understood, Nandini? How it is same? It is different, right? It is different, right? See, if you have pseudomonas, okay, pseudomonasக்கு முக்கியமான risk factor என்னன்னா, again, எப்ப நீங்க pseudomonas வந்து கண்டுபிடிப்பீங்க? When you will identify pseudomonas, whenever your culture sensitivity has pseudomonas, risk factors are present, and culture sensitivity shows pseudomonas. MRS also has risk factors plus sputum shows MRSA. Then only you are going to call it as MRSA, right? Along with risk factors, there should be a proven one, right? Pneumonia. Which one? This one. Acute infection of alveoli or interstitium with no lung destruction is going to be pneumonia. Okay, but whenever it is going to be present like this, then the patient is going to have type 1 respiratory failure. And whenever the patient goes for necrotization or abscess formation, he is going to develop type 2 respiratory failure. Type 2 respiratory failure. Okay, understood? Okay, so we'll meet after 10 minutes. Okay, meet after 10 minutes. Again, we will resume the session. Okay, Vanco resistance, then you Ticoplanin. You have streptogramins. You can go for streptogramins. Okay, quinopristine, dalphinopristine, etc. So again, it is if I'm going to go into it, it will go into pharmacology again. Okay, so they are called streptogramins.